over the years, this particular research program has evolved to also target both substance use and sexual risk behaviors, and most recently also obesity prevention. Actually, Sarah Messiah, faculty member in your department, and I are working together on this NIH grant as multiple PIs. So I won't be presenting on that work, nor some of the work that we have going on internationally. We have 2 funded projects right now, one working in Ecuador and one working with Chile. So I'm really going to just be speaking about the US, mainly the South Florida studies, and those focus on substance use and sexual risk behavior prevention. So with that said, I'm actually a walker. Actually, I just realized, I don't know how I'm going to walk. If I can, I don't know. I wonder if I can get this USB plugged in. Is that possible? I'm sorry, I just thought about it. Thank you. So this research program has over the years been funded by NIH CDC, and what makes me most proud, other than the fact that we have been able to work with thousands of families here in our community, is that a lot of the studies that have spun off of this particular research program have been to early career folks, including Yanin, who led an online adaptation of this intervention, and also Sarah St. George, also another junior person who used this foundation along with her dissertation to develop a family-based online intervention for Hispanic youth, and that's part of her K right now that she's working on. Okay, so first of all, what is Familias Unidas and what does the intervention look like? So Familias Unidas is an evidence-based preventive intervention specifically for Hispanic youth. We work predominantly with the parents, where the parents are the agent of change for the youth outcomes. The intervention is delivered over a 12-week period with sessions once a week. 8 of those sessions are multi-parent group sessions where a group of 12 to 16 parents come together in a group format, and they are, in a very participatory fashion, taught different types of skills, parenting skills. So for example, skills around effective communication, skills around parental monitoring of peers, skills around being involved in their adolescent school world, parental monitoring of peers, and then we get to the more sensitive topics such as building effective communication skills around drug use and around sexual behavior. In addition to these 8 multi-parent group sessions, where we use a number of different strategies, including but not limited to role plays, there are also 4 family sessions, and these are one-on-one sessions with the facilitator and the adolescent and the parent or any other member of the family that they wish to have in the session. And this is really the opportunity for the parents to practice some of the skills that they learned in the previous group sessions with their own adolescent. The facilitator is there to be supportive, to be a guide, but really to take a step back and again, let the parent be the agent of change and really give the parents the power, be empowered to be able to create change in the adolescent outcomes. So just briefly, as I said, it's an evidence-based intervention. If you're familiar with some of the national registries in which different types of behavioral interventions are registered, we're in a number of them, including Blueprints and CDC's evidence-based consortium. Briefly, if there's some psychologists or psychologist interns or residents in the room, you're probably familiar with some derivative of this figure. The theoretical model of this intervention really builds on Romper Berner's work on the social ecology. There you see the adolescent or child in the middle. And essentially this model posits that adolescent behavior is influenced by a number of different levels of influence, including those levels of influence that are most proximal to the adolescent, such as the school, peer, and family world, and then those systems that are a little broader or that are more macro, such as parents' level of support, parents' level of work, and even those dealing with the exosystem, including but not limited to cultural mismatch. For example, we're dealing right now with immigration policy, right, and the impact of that to families, to youth, and to others. So it builds off of that work. So how does the intervention accomplish its goals? And I think I've gone through some of this already, but essentially the intervention instills hope for these parents. So we work over the years, we've worked, as I said, with thousands and thousands of families, and approximately 50% of the families that we have worked with over the years are Hispanic recent immigrants who have been in the U.S. 1 to 2 years. And what ends up happening, as many of you may know, parents do not tend to acculturate very quickly. Adolescents do tend to acculturate, so this cultural mismatch that happens between the family starts creating issues within the family, for example, gaps in communication, and this really makes parents believe that they are alone, that there's no hope for their child. And really what it is, it's a really relatively normative behavior, normative developmental trajectory that the adolescent who's acculturated is going through here in the US. And so we really do try to instill hope in these parents, in these families. As I mentioned earlier, we really empower the parents, and they are the agent of change within the family. So that is really the goal of this intervention and all of the work that we do on our team, and really that the Center for Family Studies, which is where I started as a graduate student, all the work in that center really focused on the parents being the agent of change. One of the things that, the last thing I'll say about this slide is the importance of creating support networks for the parents. And I'll say this now, and maybe in 20 minutes I'm going to regret saying this because of a slide I'm going to show, but one of the things that we do try to do in these multi-parent groups is to foster and develop parent support networks. Again, because a lot of these families are recent immigrants and have been here in the US a year, maybe less, they don't have a social support network around them. So with this group of 15 to 18 parents, we have some videos. Actually, I wish I would have brought one. But you'll see that these parents really begin to develop relationships over this 3-month period, and many of them exchange phone numbers. And that's a vehicle by which they, other parents, can help monitor the children of a specific parent. So over the years, we have moved, and this is a figure from the Institute of Medicine that was published in their 2009 book on preventing emotional and behavioral disorders among young people. And it really, if you take a look for the physicians, it really parallels the model, the FDA model. Stage 1, when you're developing a medication and testing and really focusing on safety. Then stage 2, the larger trial, stage 3, et cetera, et cetera. So this really parallels that from pre-intervention work. And this is when we were really doing a lot of our formative work a little over 15 years ago and gathering some qualitative and actually quantitative data from parents, from youth, from school counselors, and I say schools because initially we started delivering this intervention within the school context. So a lot of data were gathered, and this really helped inform the intervention. Then we moved on to complete a number of efficacy trials that were either funded, as I mentioned earlier, by NIH or CDC. We got some very promising effects, and as you'll see in a second, both using control conditions that were prevention or treatment as usual, whatever the system was implementing at the time, or in some trials, the control was an attention control condition where we match for the dosage, the format, and the intervention delivery. So in both types of study designs, we have found that the intervention has had an impact on drug use, cigarette use, in some cases, hasn't always been replicated in alcohol use and then in sexual risk behaviors. Not that long ago, we completed a fairly large effectiveness trial. Was completed in almost 20 middle schools in the Miami-Dade County Public School area, where youth in these 20 middle schools either received treatment as usual, whatever the school was giving at the time, or the particular intervention. I'm actually going to speak a little bit about that study. We're now moving in a couple of different areas, including thinking about implementation. We actually have a study, I'll speak about it in a little bit, where it's sort of a hybrid effectiveness implementation trial where we're looking at, nonetheless, the effectiveness of the intervention, but also measuring implementation processes that could help inform a large-scale implementation trial. And I'll talk about that in just a few. So I won't go through all of the studies and all of the results, but this is one that I do briefly want to talk about. This was published in JAMA Pediatrics. Actually, at the time, it was, I guess, the Archives of Pediatric and Adolescent Medicine. And we were working here with a very indicated sample of Hispanic youth. And what I mean by indicated, these were youth who were exhibiting quite a bit of behavior problems Many of them were recruited through the juvenile justice system, through their diversion program, and others were recruited through the school system because they had committed some type of misdemeanor, and the principal had decided that if the adolescent participated in a prevention program such as this one, then there wouldn't be any further consequences. Here's the trial that I referenced earlier. This is one that I will go into a little bit more detail. By the way, as you can tell, not only do I speak loudly, but I also speak quickly. So if you have any comments, questions, please just raise your hand. I'm more than happy to pause and answer any questions. This is the trial that we completed. These were published in the American Journal of Public Health recently. We recruited and assessed 746 families, as I mentioned, across, actually it was 18 middle schools in the county, public middle schools in the county. And we randomized half of them to the community control or treatment as usual, and the other half to the intervention. We followed these families, both parents and youth, and collected different types of behavioral and psychosocial and a lot of family data, as you would expect, given that a lot of the mechanisms of action that drive the effects of the intervention on the outcomes are things like parent-adolescent communication, parental monitoring, parental investment, things that we're really interested in and that we specifically target in these 8 sessions, in these 8 group sessions. We collected data at 6 months, which coincided with just a couple of months after the end of the intervention, then a year and a half later, then 2.5 years later, to see how everyone did. Here's a brief snapshot of the demographics of the population. The average age was just shy of 14. In the past, traditionally, we have worked with 8th graders. There really is a rationale. It's not totally random that we're working with 8th graders. One, drug use and sexual risk behaviors tends to peak in the 10th grade. So we are really able to work with and capture youth in the 8th and 9th grade before these behaviors escalate in the 10th grade. So really, in some ways, it's maximizing our chances that we're going to detect a significant effect size. That's one. The other, it's at a time right before a major developmental transition, and in this case, that's the transition from middle school to high schools. And major developmental transitions are great times to intervene, particularly with parents, because they're anxious, there's a concern about what's going to happen to my child when he or she transitions from middle school to high school. So it's really a great time, and it really makes it easier in a lot of ways for this, not to say it's easy, but it makes it easier for the staff to be able to successfully engage and enroll these individuals and these families into our studies. As you can see, it's a fairly low SES, socioeconomic status sample, with most 2/3 of our family reporting an income of less than $30,000. And as I said earlier, about 50% of our families are recent immigrants, and here it was about 45 to 55% were born in the US. So what did we do for this particular study? As I mentioned, we worked with a lot of middle schools. This was the first time that we were really thinking about, all right, we are not going to be delivering this intervention ourselves. We have had people like Maria who are absolutely stellar on delivering the intervention, but we want someone else outside of our research team to be able to deliver this particular intervention program. One, is it feasible to do that? And two, does the intervention have adequate or similar effects as to what we had before? So we trained about 43, 44 school counselors to deliver the intervention, school counselors and social workers. We had a couple that dropped out early on voluntarily. Others did not drop out voluntarily. We dropped them out because after the training we realized that they were just not the perfect fit to deliver the intervention. So 36 stayed behind to deliver the intervention. We trained them in a relatively short period of time over a 4-day workshop. And then we did weekly supervision of these school counselors or social workers. We monitored fidelity to the intervention. This is a very standardized or manualized intervention where there are the different things that the facilitator has to do at every session. And so we videotaped all of these sessions, randomly selected videotapes, to then rate how well the facilitator was doing. So that was really key to be able to deliver this in the school system. Here you see what the average fidelity rating was. Basically 0 was they did a horrendous job, 6 they did a perfect job. Generally somewhere between 4 to 5 is they did a good job, with 5 being they did a very good job, and 4 they did a good job. So we're tough graders, so they got a 4.1. To give you a sense, when Maria used to do this intervention, she would be around the 5.0, 4.9. Okay, somebody who had been doing this for a long time. So it's about almost a point less, but nonetheless, we thought that was good enough. How did they do in terms of attendance? So one of the things in this literature is family interventions have a problem. Yes, they do have impact. There's been a number of interventions that have been evaluated for non-Hispanic whites, for African Americans, and for Hispanics. All of them have very similar elements if you really look at them. One of the common challenges of these interventions is that it's very difficult to engage parents to come to the sessions for whatever reason. Parents have other responsibilities. In the case of our families, they work 2 jobs. You know, the sessions are generally held at 6 o'clock. Sometimes transportation is an issue. Sometimes childcare is an issue. Although we try to problem solve and circumvent some of these challenges, nonetheless they exist. So what did the attendance look like? You can see that on average, only half of the sessions were, or a little over the sessions, about 6.5, were attended by our families. That's not as good as when Maria used to deliver the intervention, that it was about 8 to 8.5 sessions. So less dosage received when the school counselors delivered the intervention. Why is that? We are a little bit more persistent. If a family doesn't come in, we will call and call and call. We'll even show up at the house and say, hey, listen, we just want to remind you, there was a session yesterday, there's one 6 days from now. School counselors, it's very different, right? These are personnel that are being paid by the school. They have their own responsibilities. They're likely not going to go, although some did actually, but not all of them are going to go at 7 or 8 o'clock to a family's home to remind them that they didn't show up to a session.
Was this held at the school?
Yes, it was held at the school. Yeah, absolutely, good question.
And these are the sessions, this is called the 8 multi-family.
Exactly. Yeah, great questions. We actually get higher dosage at the 1-on-1 sessions than in the parent groups, in the multi-parent group sessions. You know, here's generally what we see in all of our interventions. We generally see an increase in some of the mediators. There's always 2 that we typically see an increase in relative to the control condition. We generally tend to do very well in improving parental monitoring of peers. We generally tend to do very well in improving parent-adolescent communication. What's really interesting, we only see improvement of both of those during the course of the intervention and a little bit thereafter. After that, it just sort of levels off, and we do not continue to see increases over time. In terms of the outcomes, I'll sort of skip here, so maybe a little bit too technical, but basically what we show is that we do have an impact on drug use. We do have an impact on sexual risk behaviors. What's really neat is that we generally see the impact on parental monitoring and communication first. We don't see any improvements in the outcomes about a year later, during that first year. We see them after that. Okay, and there's some hypotheses that can be drawn from that. If I'm an adolescent, and I would say, yes, mom or dad started changing their behavior. It's only been a couple weeks. You know, are mom and dad gonna go back to the way that they were parenting? So it sort of really takes a little bit, and you know, some of these skills are not developed overnight. So it's not until about a year that we really start seeing the improvements in the outcomes. And actually, interestingly enough, you see that the outcomes continue to improve, in this case decrease, over the 1.5 years, 2 years, 2.5 years. So these are really delayed effects, and they really do continue to improve over the course of time. So about 5 years ago, Janine, as I mentioned earlier, led the development of an online adaptation of this particular intervention. What was the goal, and why did we decide to do this online intervention? For a number of different reasons. One, we want to have more reach. Okay, I think it would be totally ignorant of us to think that this intervention, although has good effects, that we're going to be able to reach a large segment of the population, given how resource intensive it is, right? It requires 2 facilitators to deliver 8 multi-parent group sessions of a size of 12 to 15 or 12 to 16. How many groups would we have to run? 1. So we wanted to address the issue of reach. Second, I mentioned that and showed that attendance at these sessions is sort of mixed, about 50%. Childcare needs, transportation, multiple jobs, the time of the session is not convenient, whatever it may be. So that was the goal. Can we minimize these problems so that we could target a larger segment of the population and hopefully have the same type of impact? So this is what this online intervention looks like. On the right-hand side, the 4 family sessions, which again, as a reminder, these are live sessions with the facilitator and the family so that parents can practice the skills that they learn in the group. These sessions are still live, but they happen through a Skype-like software, okay? So that they can really happen at any time. Parent doesn't, mom or dad, or grandma or grandpa, do not have to come to the schools, do not have to come to our research offices to receive this session. They can log in online, essentially at whatever time they tell us, and we will be there for them to deliver this 30 to 45-minute session. Now, the 8 multi-parent group sessions were substituted by 8 online videos. Now these online videos, and I'll show you an example in a second, consist of 3 different components. The component in the top is a telenovela series. There's 8 episodes. Again, remember, there's 8 group sessions. Now there's 8 telenovela episodes. Each one of these telenovela episodes are 6 to 8 minutes in duration, and they introduce and map on to each of the 8 different topics that are covered in the intervention. Communication, parental monitoring of peers, parental involvement in the schools, communication around drug use, communication around risky sex, etc. Anything and everything you think a Hispanic telenovela should be, this is. There's drama, it's climatic, there's a cliffhanger at the end, you name it, okay? The second component, actually, you see, this is Maria right here. She's our Oprah Winfrey, okay? She runs a talk show format with a real audience, a live audience, that we recorded, then we edited, and then that made up part of these videos. So parents at home get a telenovela, they're looking at the 6 to 8 minute episode, focusing on communication, oftentimes the parent not communicating well with the adolescent. Then Maria says, audience, what did you think about this video? Do you think that mom and dad were communicating effectively with this child? And you at home, what do you all think? How do you communicate with your child? So that was the goal. The goal was to mimic the parent group and to some extent have participation involvement from those on the other side watching. It's not perfect. Earlier I said that we try to foster parent support networks. Here we can't do that, or at least not yet. So we're working on it. The third component, also to mimic that participatory, interactive style of the intervention, we developed some interactive exercises so that parents at home can complete them while the audience members are talking about it. So here's one example. Actually, I have it in the video, so I'll show you that. And the responses to these interactive exercises we often use to tailor the individual family session. So a little bit of personalized medicine there, if you will. Here's a video. I probably won't see the whole thing, but just so you can get a ooh.
eHealth Familias Unidas primary care consists of 12 sessions, 8 mock parent group sessions, and 4 online family sessions. The following video demonstrates the building blocks of each mock parent group session: an episode of a culturally syntonic telenovela or soap opera series, discussion during the videotaped parent group session, and an interactive exercise. The first component is a telenovela series. The following is an excerpt.
Hey, ¿qué haces en el sofá? ¿Y tu hermano?
En el cuarto. Tenía dolor de cabeza y yo no me quería acostar. ¿Cómo está tu jefa?
Mejor que yo. Es una melodramática. No se rompió nada. Debería actuar en novelas. Bueno, hasta mañana.
Wait, Mommy. I lied about Darwin.
Gabriela, please. Español.
Tenemos que hablar.
Tú siempre escoges los peores momentos.
No lo escojo. Son los únicos chances que tengo. Siempre estás corriendo o cansada.
Bueno, está bien, dime, ¿qué te pasa?
No es mí, es Darwin. Parece que...
Gabriela, perdón, hija, pero de verdad estoy muerta. Mañana tengo que llevar a doña Silvia al radiólogo súper temprano. Hablamos en otra ocasión, ¿ok?
Yeah, sure. En otro momento.
Culturally syntonic with the population. And also, one of the challenges with online interventions, if any of you work in this space, is that individuals in general tend not to continue watching or continue participating in online interventions. They may watch the first session, they may watch the second, but how do you continue to keep parents and families, in this case it's parenting intervention, but in others, whether there's an individual format, how do you continue to keep folks engaged? So this was sort of, at least back then, our best attempt to make this engaging so that families would continue to participate in the intervention. So briefly, we completed, Yanin led the study where 230 families recruited from the school system, again, school counselors delivering the online intervention, were randomized to one of these two arms, and they were followed up for 1 year. You don't want to go through it. Again, same mechanisms of action, communication and parental monitoring. We had an effect on both of those. And then at a year later, we did have an impact on substance use. But here's sort of where I want to focus as opposed to the main findings themselves. Again, prior effectiveness trial face-to-face, 6.4 sessions attended on average. Effectiveness trial with this online intervention, almost 9. So again, we were able to have parents watch more of these sessions than we were able to make them come to the sessions. So I would say that mission fairly accomplished. Obviously we would have won 10 or 11, didn't quite get there. So this here was significantly higher than in all of our face-to-face trials, both in terms of the number of group sessions attended and also in terms of the family sessions. And here you see the percent of families that completed all 4 of the family sessions was pretty high, 72%. It's generally about 50%, actually even a little less than 50% in some of our other trials. Okay, so about, I guess about 2.5 years, it's been a long time now, 2.5 years ago, we started thinking about, this was around the time with the Affordable Health Care Act. We started thinking, all right, so is there a way to begin to work in primary care clinics and to have individuals that are embedded within the system deliver the intervention, whether it's an intern, whether it's a resident, whether it's a psychologist, if there's co-location happening, whether it's a nurse, whoever it may be from the system. So we did some pilot work, and actually this was in large part, it happened because of Jason Jen. Thank you, Jason, who made some very key connections. Actually, we met with Larry Friedman as well, so thank you. And we were able to connect with key individuals, either as part of the pilot study or as part of the large NIH trial that's currently in its first year. We were able to work with Audrey Ophir and with Lisa Gwen and with Lourdes Foster, and then a number of different private clinics out in the community. So as part of the pilot study, we were really interested, not really in collecting behavioral outcome data, which we did, but just to see, all right, is this even possible, right? Should we even waste our time in writing, a 5-year NIH grant if it's not doable? So is it doable? We were actually able to enroll about 90% of the families that were eligible, of course, through the system. In our main trial, we're not doing as well. It's probably about 67, 68%. We have some hypotheses as to why that is. Here, as I mentioned, we were not really collecting any data. We were collecting demographic data. The assessment battery took 5 minutes. Now our assessment battery, we wanted to keep it short, and for us short is 30 to 40 minutes. So what ends up happening is you have a family that comes in, between consenting, generally takes about 15, 20 minutes, then the battery, 30 to 40 minutes, and then 5 minutes showing them how to log on to the session. Before we know it, an hour, a little over an hour has come and gone. And so some of these families, when we approach them, they say, I don't have an extra hour to stay in the clinic. So we do end up losing about 25% of the families because they just don't have the time. So basically, we collected some qualitative data. These are data that were collected by actually a master's student of mine and actually ended up getting published. But these are some of the themes that emerged from her qualitative work. The parents trusted the physician, right? So no surprise. Parents have been coming oftentimes to the same, we're working with 12 to 15-year-olds. Parents have been coming to the same pediatrician with their child for 10 years, or more. So, and they also preferred the primary care setting over the school setting. And, we delved into this a little bit more, reason being, makes a lot of sense. Parents said, when my school counselor, my child's school counselor gives me a call to say, are you interested in participating in a parenting program? It means to me, I'm not doing well, or there is something that my child is doing or not doing that the school counselor thinks that my child and I should be participating in this program. So there's some stigma to that. Whereas in the physician, that's not necessarily the case. The physician's saying, there's this program, this study that's happening, or this particular intervention that's happening here in this clinic. We think you would find that interesting. So there's less stigma associated with it.
So Willie, in this case, you're looking at sort of all families?
All
so
families.
It have to be at risk.
Exactly. So these are all families, as long as they're Hispanic, 12 to 16 years of age, and you're interested in participating, you're in. Here's a quote. I'm cognizant of time, but it just has to do with that trust issue, that the parents really trust the physicians. In terms of the clinic personnel, we interviewed the clinic staff, including some of the physicians I mentioned earlier, what they thought. They thought that the intervention was valuable. They did think they liked the flexibility, that it was convenient, could be done at home. There were some challenges that were raised, including the staff, right? Who was going to be delivering the intervention in their team, and also issues having to do with sort of logistics and space, for consenting, for example. And so those are some of the issues that we've tried to minimize. There's challenges, spaces. A challenge here at the medical school is a challenge everywhere. So, but we really tried, you can ask Dr. Ophir, Dr. Foster, Dr. Gwen, we really do try to be that hidden partner, that you're not there unless you're a family and we're trying to enroll you. I'm going to finish off with these last couple of slides and then give the last 15 minutes for Q&A. As I mentioned earlier, we do have a fairly large effectiveness trial that we started about a year ago. So we're at probably about 5 months in to recruitment, where the target is 456 Hispanic youth and their families in different clinics. Not only the ones here associated with UM and Jackson, but some of the private clinics, and very soon also starting at Miami Children's Hospital. And we're looking to essentially replicate our findings. Does the intervention have an impact in terms of drug use and sexual risk behaviors? This is our first time collecting biological data to look at, whether we're able to prevent the incidence of STIs, particularly gonorrhea and chlamydia. We're really now taking the time and doing a very extensive economic evaluation of the intervention and of the study. So one thing is we have an impact. The second is it worth the cost, essentially? So we're working with a health economist to assess whether this intervention is cost effective or not. We're also looking at trying to understand mechanisms of action and also trying to understand for whom does the intervention work best for, and also under what context. So it may be, I don't know, that the intervention at the end of the day doesn't work as well maybe in the mobile clinic, and maybe it works better in more traditional pediatric care settings, either because of the setting itself, or it may be confounded because of the population, right? Maybe mobile clinic is even lower SES, maybe there's less access to the internet, maybe, so whatever reason. So these are questions that we're going to be looking at, in addition to data that we have collected from the physician and from some of the staff in the clinic, including but not limited to their attitude towards evidence-based interventions, their leadership style in the clinic, etc., to see how any of those or a combination of those factors influence whether the intervention works or doesn't work. Here's some of the team that were present. Actually, I think you see Dr. Ophir. Actually, I think everybody, all the physicians except for Dr. Glenn were here. Okay, average attendance. These are data from our pilot study. We are currently about 20% in for our recruitment for the main trial. So these data that you see here are preliminary from our feasibility acceptability study that we did about two and a half years ago. Average attendance at the sessions, you see that it's pretty comparable. For the school-based study, it was 8.9, I think, so almost just shy of 75%. Same thing here in this feasibility study, 75% watched the sessions, or 77% rather, so very comparable. And with that said, I promise to leave 15 minutes at the end for Q&A. I think I'm right where I should be. And I'd just like to thank our funders. The Institute of Medicine here played a major role in this particular study. They really made some really important connections with different folks, including the leadership of some of the major pediatrics boards and associations who are actually consultants on this grant, as we begin to even think about scaling up this intervention. If it does have some effect 5 or 6 years down the line. And then NIH and CDC, who have been our funders to date. So that said, thank you to all of our families who have participated over the years. So thank you all.